Welcome to the Oral History program, Professor Muraleedharan. We're very happy to host you today. And before we dive into the important questions, I would like you to give a brief background about your early days, schooling, college, then how you got into IIT Madras.
Okay. Good evening, Professor Sudarsan. I would like to first of all thank the heritage team, namely Mr. Kumaran and Mamta and the team for inviting me to be part of the series uh, of our institute of once our own life here. I joined the institute as a PhD scholar, to be exact, on the 12th of August 1983. That was the first day when I entered the campus as a IIT student, PhD student. When I completed my PhD in 1988 from the Department of Humanities and Social Sciences. But to go a bit before 83, where I was and what I was doing, my schooling, complete education up to my 11th class was in Tamil Nadu. My father was in the police. So every year we used to be transferred. He used to get transferred from one place to another. So I began my schooling from the corporation school in Nungambakam here, and then to Madurai, then Kovilpatti, Tanjavur, Dharmapuri.
So you have
Ended
traveled all over Tamil Nadu.
quite a few dialects I know. I can speak in Tirunelveli Bhasha to Madurai and Coimbatore and so on. Then I studied, of course, in Tamil medium and government school all along, and I completed pre-technical course, which is the first year of a diploma program in PhD College, Coimbatore, which is equivalent to the PUC. Actually, a little more than that. We used to have workshop and graphics as well. Uh, then I went to Pilani with the intention, with the hope of doing engineering, but I ended up doing economics and I continued. Then I worked for about close to 3 years as a research assistant at the Administrative Staff College of India, where I had good exposure to field work. That became my both good training in doing field work based research. And
This was in
83
Hyderabad.
Hyderabad.
Okay.
Then I joined here as a PhD student. So my supervisor, my teacher, guru, mentor was Professor S. Ambirajan. He had joined this institute in 81 at that time. Incidentally, 81 is the year when our department started formally a PhD program. Until then, our faculty used to do the PhD as a part-time faculty in Madras University or elsewhere. So at that time, I think Professor Indrasan, who was the director, uh, decided that we should have a PhD program in humanities and social sciences, since we are an independent autonomous institute ourselves. So that's the quick summary of my journey through schools and up to IIT Madras. So 83, and I completed, I submitted my thesis in 87 October. My viva was on April next year, and the same year, there was advertisement for lectureship. So I applied for it, and along with me, one of my seniors in the same economics area also was offered. He didn't join, and another woman candidate, she was also offered, but she joined Pondicherry University. So I continued since then. So very broadly, I worked on the history of healthcare in South India from the turn of from early 1900s to 1940s. But my MA was in economics, and what I did, you can take it as part of economic history of South India. Broadly, it's entirely based on archival material. So we had a group of nearly 10 PhD scholars, all of them working on the same period in Madras presidency. Myself on healthcare, history, and somebody on agricultural commercialization of agriculture, a couple of people on trade union movements, someone else on education policy, and so on. So we used to complement each other's work, and quite a large number of PhD students during 80s. We had, I would call it, looking back, as that period as our own golden era. Very few institutions in the world could claim to have had such a large number of students, PhD scholars, working in that period of interwar years, from early 20s to 40s, on one region called Madras Presidency. So that's the background with which I entered our department. And
So how was working with Professor Ambirajan?
sorry?
How was it working with Professor Ambirajan?
Well, I can be very brief, and I can also go on.
Because we have read many of his articles in the Hindu and his books also.
So to begin with, so when I joined, I had my own two-page proposal on what I would like to work on, and it was I remember very clearly about analyzing the government budget allocation for healthcare in the context of 80s and 70s and 60s, and how should government spend the money in future. So what he said was this: you can choose a topic of your choice. No issues, but he said, I have only two conditions. One, you should work, you should go back in time and look at the history, what happened in the topic in which you are interested in, namely Madras Presidency. And preferably, the second condition was concentrate on the interwar period, that is the period between 1918 to 1939. So a little bit back and forth you can go, and there are reasons as to why economic historians focus on this interwar period also. So it meant that you have to go back and work in the archives, Tamil Nadu archives, as well as other archives which will have records of this period. Other than that, he would guide you in the most gentlest manner. What we used to do is he used to say that if I see you every day in the corridors, that means you are wasting your time. I have a schedule, and we meet once in 2 weeks. The 4 or 5 of us will come as a group, sometime individually as well, but once in 2 weeks. Spend about an hour or two, but we will eventually end up spending about 3 to 4 hours, because 3 or 4 of us are together, and he would ask us to summarize what kind of documents you have read, the originals and other secondary literature. So that's the only condition he would have. Every 2 weeks you summarize your progress, and then he would generally suggest gently read some allied papers here and there. He would not insist in terms of timeline. In a sense, he will say if you are finding it difficult to make progress, but he would like to know what kind of problems you are facing, why you are unable to read, and he will give some supplementary reading, so on. So in that sense, very liberal, in the sense if you show that you are reading in a very broad, wide range of literature, that would excite him. So if I every time went and say that something to do with healthcare alone I'm reading, he would, historically speaking, he would listen to it, but he would be even more excited if you are able to connect with wider literature, and not only in English, journal articles and so on, but even otherwise, what we call local languages. So there are autobiographies of physicians of the British period who lived in 1800s, late and early 1900s, and if you had bumped into that, stumbled upon such books and summarize, so you would be more excited. So the breadth he would insist on. What he would say is the depth would automatically come when your breath goes up. So initial first few years, he would say that, and have a breath and let that breath grow organically. The depth will organically will happen. And then, of course, towards the end, you would find yourself reading more and more in terms of depth, because you are in the writing stage. And one thing you would say is that what you're reading, have a systematic way of making notes. So we would, in fact, there is not a single week when his review of a book or a report would not appear in the Hindu newspaper. So very prolific writer and reader. And he used to also write once in 2 weeks in Economic Times, something contemporary. So what he would say is that you must, as he would say in Tamil, பேனாவை எடுத்து ஒரு வீச்சில் எழுதிடணும். You just write in one beach. I mean, one sitting you write. Otherwise, if you keep editing as you are writing, you will never complete a sentence. But of course, you should edit after you write. But then, what you are writing, first step is making notes, and then out of which some thinking, and then start writing. And I think that really helped us in writing our thesis as well. Otherwise, most of us will have a lot of hesitation in writing our thesis,
So actually,
because we postpone it to the end.
Yeah, this is now in many writing workshops and technique of writing called free write, where you just pick up your pen and start writing without any stop.
So some good books I also bought later on, and I shared with my fellow researchers also, that when you're writing, have what we I call as structured vomiting. So you do have some ideas, but then of course it's useful to have some structure, but just pour it out. It can, the sentences, some of them will be beautiful, some of them will be terrible, some of them will be repetitive. But just don't worry, tell your left brain, whichever does the editing, to keep quiet, and tell the left brain you will get your turn, wait, and then write what you call as free writing. And then next round you sort of edit it and clean it up. So that is something that in a very gentle way he imparted that idea to us. And the breadth in reading. And the breadth in reading, you pick up a little bit, not as much as he was able to display and is from his own reviews in the Hindu. The range would be uh, very vast. So that sort of Brahmandama, like so many issues he is able to grasp and link. That's the way he would pass on the message. Next day, in fact, on Tuesday morning itself, in the afternoon when we meet him, he would say, "Did you read my review?" Sometime he would say, in such a way that unless you have read it, you can't talk about it. So you can't bluff your way, yeah, yeah, I read it, and so on. So the urge to read widely and then slowly develop the depth uh, is a great lesson that we try to imbibe. And of course, even today, it continues, of course. Uh, so that's a great lesson, I would say, uh,
So
we
how
have
about your,
received.
yeah, how I think from what you have described, we are able to discern that the emphasis on a broad reading and also varied reading, plus the emphasis on history, economics, and public policy has kind of given a very nice foundation for your later specialization and also.
And this is one thing that all of us, another learning about somebody critiquing or commenting on what you have written. So uh, when the reviewers comments we received on my thesis, actually I ended up writing practically one more chapter. uh, so one of the examiners asked some questions and she said it must be extended here and there. I frankly was not receptive to that, like most others. And he was also, in a way, said that whatever it is, finally you have to constructively, positively respond. First of all, don't assume that. Go with the assumption that there must be some intrinsic value in what the examiner is saying. Then your mind actually starts working. That is a great lesson, I think. Otherwise, we tend to defend ourselves by saying any comment critically that you see on your paper or a thesis, a chapter, you tend to defend, no, it's already there. Don't you? If you read further down the 20th pages, you will find that there's a remark that all that for some reason you must respond positively on the assumption that there must be some intrinsic value in it, because after all, uh, he or she doesn't know me and nor I know her to write some critical point just to keep to fixed somewhere. So that is a very simple thought, but many of us
We
tend
become
not to
defensive.
take it
Yeah, yeah.
in that fashion.
When we see a critique, we become defensive. Actually.
So that actually he instilled in us by making us go through. This happened also with my other batchmates, similar comments. And later on, of course, when the Viva took place, it so happened that um, that was my first conference in Delhi as I was finishing my PhD. So in the same flight, I was coming back. That was my first flight as well. Coming back to Chennai from Delhi. The next day was my Viva, and the examiner was in the same flight. So, and she took the paper that I presented in that conference in Delhi. And by the time I got down, all the 20 pages were practically rewritten in red ink by her. So I just couldn't accept that someone can uh, make so many corrections almost every sentence without altering the content, you know. So those were the some of the lessons that I learned from him and from his colleague who happened to be his batchmate, that person who evaluated, very fair, and he made me respond positively to that. So that's there are many more other things that I can recollect, but anyway, I will let you proceed.
So then you joined in 1988, right?
88 August.
So then you worked for 4 years, and then you went to Harvard for a postdoc, right?
I worked for 7 years. 1995, 96, exactly 12 full months I went to Harvard School of Public Health as a postdoc. So I had a postdoctoral fellowship, it's called Ford Fellowship in Economics. That year, 95, 96. So the fellowship first is given to you, and then the team which selected you would also help you find a affiliation with universities. So I had some contacts by then, both in Harvard School of Public Health and the London School of Hygiene and Tropical Medicine. So I was quite greedy. I wanted to spend 6 months there and 6 months across in Harvard. So the professor in Harvard suggested you can take either come here or go there, but 6 months would be too short for you to do something substantial. So you decide. So I decided to go to Boston, Harvard School of Public, because I had some friends, former BTechs, uh, whom I knew, and one of them said that he can take care of me first week or so to find a. So that was one important factors that made me decide to go there. So I was there for about exactly 12 months. Then 95, 96. 96 August I came back.
You were in the School of Medicine?
I was in the School of Public Health.
Public Health, okay.
So it's all one complex, medical and public health. So it is actually, that program is called Takami Program in International Health. Takami, a Japanese who was also from Harvard, he was the president of the Japanese Medical Association and Public Health. So there was a program endowed with some endowment from his contribution. So the program is named after him. I was a Takami Fellow. Every year they would have about 10 to 12 Takami Fellows from different parts of the world. I was the youngest that time. Normally people with some 10 years of experience, field work, either as a physician or social scientist. So I was there. I did some coursework, formally sat through some coursework. I also wrote 2 research papers on India. One of them was very interesting. It's a review paper, review of US healthcare system, particularly how technology and competition played a role in controlling or cost of care. I say controlling cost of care, it hardly could control, but how it impacted the cost of care. And what we may witness, given the context in India, given the experience of technology and their healthcare system, what we may witness in the Indian context. That was the essay. And so I would say lot of insights that I could derive from there. We are still discussing in the Indian context. Difficult to, as you know, control cost of care, difficult to control the momentum of technology, more so in the global context itself, and especially in public health in India and the world over as well. So that's a brief summary of what I tried to do and learned from there.
So how was you got involved with the government of Tamil Nadu, government of India, and many other state governments as well. in terms of your work on public health and also health policy, health economics. So, from your Harvard days, how did it evolve?
It so happened that until I went on a postdoc, 100%, I would say almost 100, 90% of my work was historical. Continued to be evolving from my PhD work. Then one of the papers I wrote, which was published in Economic and Political Weekly, before I got the fellowship, was one major reason why I got the fellowship. That actually looked at the challenges in improving the access to healthcare. What are the public policy challenges? I wrote that paper, uh, and I continued both during my fellowship and later on. So happened that after I returned, I had an opportunity uh, to do a study for the Tamil Nadu government. Very simple in nature but very laborious, which is to estimate the cost of providing primary care at the primary care center level. Very simple, very straightforward empirical work, but no one has actually looked at what it costs per patient per visit in a primary care center. It's as simple as that. So, but then it was sponsored by the one of the international agencies working in Tamil Nadu, Danish government agency, Danida, and the samples were taken from Salem district. So I did that, and since then, somehow my engagement with the government of Tamil Nadu in particular grew, and in many ways, I was engaged in some kind of studies. Um, so that's how my journey with the government actually started. I was engaged in a number of workshops, symposiums. Uh, then there was a phase from early 2000 2, 3, the Tamil Nadu Health System Project, which was funded by World Bank for the next 10 years from 2005 to 15. The major project. I was engaged in the initial discussion and preliminary studies. Some of the workshops were carried out here, closed workshop, of course. So that took me even more closer to the government. And also a couple of studies with the central government. You may recollect WHO macro commission on macroeconomics in health, which was chaired by Jeffrey Sachs at the time in late 90s. So they also funded about 10 different studies in Indian context. The funding came through another organization in Delhi, namely called ICRIAR. So I wrote a paper on the prospects for private-public partnership in healthcare for primary care at that time. So that took me again closer to central government, some of the studies for them. So slowly my work was more on more contemporary issues, working directly with the government. And I had my one finger on the archival work. Occasionally, I will, with my old archival material, I used to put things together and write anyway, chug along. But otherwise, practically, uh, most of my research time would go into this, working with the government, then more contemporary, more current, as they call it. Although I should say many of the issues like PPP private-public partnership. Had
So
its
just to
origin
just
100 years ago. So that's an issue, the same issue of how to keep and attract and keep the physicians working in rural
how
healthcare,
is it now? Is it any effective?
which is
The PPP in the
PPP. Now we have many more experiments. Although even yesterday I read a very good critical inquiry into the effects of outsourcing in the American context, how it has actually complicated the system, both in terms of reducing the economic efficiency, and quality is always a question mark. So otherwise, uh, for example, how to attract physicians to rural areas and retaining them. We had experimented, I would say, earliest PPP form, private-public partnership, in Madras Presidency. Way back in 1924, the government introduced a scheme called Subsidized Rural Medical Practitioner Scheme, by which they would get 30 rupees per month if they practiced in rural areas. So per month, 30 into 12, 360, lump sum 400, they would get it. How much it comes? 30 into 12, about 400 bucks. Likewise, if we employed a nurse. So this is, I would say, not an origin. We have an origin of PPP even before that. By late 1870s, 90s, we had this honorarium physician schemes. So what it meant was that private practitioner qualified by then, who had a degree from Madras Medical College, would, unlike today, have very little exposure to large clinical experience, because the multi-specialty hospitals and so on, only government had. The Madras Medical College is basically a multi-specialty. So the private people who are not in government but practicing on their own, some of them could go and work in a government setup on a honorarium basis. That means no salaries will be paid, but they can deliver care and get more clinical experience. So it's more opportunities to gain experience, and good for the government, because you are getting the services of a physician who is not employed fully. And you would find, even when I was a young boy, you would have also seen in your hometown, your nameplate will be there with the doctor's name, and then you'll say honorary physician, Madras Stanley Medical College or something. So that's a common man will come to know who is also attached to a government hospital. So nowadays, the reverse is more common. So you will find
more doctors
government doctors working
sector
as a consultant in private hospitals. So that's another example of PPP. So now we have the contractual arrangements are more complicated. You have to really have some kind of measurable, in measurable units, one's performance, including quality. You feel the need to monitor and make payments according to that. Such complications were not so prominent, widespread then, but so that's
So
it's a problem that continues. How to have a good PPP?
It has evolved in different ways, and
yeah.
So my next question is, if you see, healthcare is one sector, and allied sector is the health policy. So from your time research, or even before that, all we are discussing is also kind of it's a synergy of healthcare and health policy. But do you think that from 1980s onwards, or even after independence, the understanding of the government to have a balance between the healthcare and health policy health administration, everything else. Has it evolved, or has it become more complicated? Has it become like less? The government has become less attentive. How would you place that?
No, no. Always the policies have evolved in a more matured manner. No, in many ways we have evidence to show. If you look at our history of our own healthcare, starting from, let's say, late 40s or mid 40s, when we had this famous committee called Bore Committee of 1947. I mean, there were commissions before that as well. But if you take that as a landmark, which is really a landmark, not many people are aware, or even those who are aware have not read even the first of the 3 volumes of Bore Committee. It's excellent. Anyone who reads will now say that we don't perhaps need to go beyond this, even what they had ambitions and stated desires. So, very holistic. So, it has evolved in many ways in terms of addressing not only providing primary care, but even looking at the education and challenges in medical education. Um, in terms of at least looking for evidence to state certain explicit policies. No doubt that the challenge of gathering evidence is, remains. In fact, it has grown. It's more difficult now due to role of several factors. If you take, for example, mortality, factors that contribute to mortality. To just take pollution alone, air pollution, which was not the case 50 years ago, 40 years ago. The both risk from pollution and mortality arising from pollution, air pollution. It's obvious now. At the same time, it is more difficult to quantify. That leads us to another question: to what extent we need an accurate estimate to have a good policy? I personally feel that in such situation, to have a good, robust policy, accuracy of the estimate is not so much an issue, but the broad quantum and direction of impact, they are more important to make decisions and design. So it is more complicated now, not only because we now realize the role of several factors, also the expectations and demands and resources required have all gone up quite a bit. Generic nature of issues, largely speaking, remains. Say, for example, nutrition, role of nutrition. Interestingly, with my little knowledge, the role of nutrition, the concept of even malnutrition or undernutrition uh, is has its origin in early 20s, not before that. I mean, conceptually it would have been there, but at least in the policy documents and in the published scientific literature, you can say that was also the time when the debate on whether vegetarianism is good or better than non-veg or vice versa. I remember reading a report study published as part of my thesis, a study that was published in 1914 or 15, the first or second issue of Indian Journal of Medical Research, carried a interesting research paper on nutritional value of Indian diets. So there is this person by name McCarrison. I think his first name was Roy McCarrison, or I forget, but McCarrison, Robert McCarrison maybe. He discovered the role of B11 or beriberi disease. So he conducted a study with rats. So a bunch of rats and divided into 4 groups, and they were fed. One group was fed the Pathan food, the other one Bengali, the other one another one what was later on termed as poor rice eating South Indian rice diet, and then Western. So all of them at the same starting point, just born, and then to the same mother. And then after about few months of feeding them, he has another picture, pre and before and after feeding them. So the thinnest, the leanest was South Indian, and the biggest was the Pathans. So, so then he said, for growth you need Pathan like that. So they're very interesting. I have one paper also on that, on early research on nutritional dietary values in India. So in that sense, if you look back now today, one of the what we call triple burden of Indian population, that of course we continue to suffer from infectious diseases, communicable and now non-communicable. Then the triple burden is in terms of undernutrition or both obesity and of course obesity could also due to other factors, but and so malnutrition, undernutrition is a big worrisome thing. So it continues in that fashion. The factors that have contributed to this nutritional deficiency, thanks to the junk food, we did not have junk food then. At that time, perhaps partly, access to resources could have been. But now you will find even in states like Tamil Nadu and other states where the per capita income has been going up, our nutritional challenges also become more and more difficult to.
So this was the reason why I asked that question in terms of understanding healthcare, health policy, then public policy, all these coming together. For example, as you mentioned,
climate change is something
change.
Is not a was not it would have been an issue then, but not as we see it now, and as complicated, contributing to the provision of healthcare. So, what are the challenges at primary care level, and how should the system be designed? And the primary care healthcare system or the whole healthcare system should be designed to deliver care in such a way it should address 3 major functions. One is, of course, to improve your health status. The second is to reduce the financial burden, not necessarily eliminate, but reduce financial stress, we call it. Even well-to-do people, one stroke could wipe up all their savings and so on. So how should it be designed in such a way that whoever pays for it would not result in the patient suffering from, to a greater extent, from financial stress as a result of seeking care. And the third one is even more difficult. That is less talked about, but we'll have to talk more explicitly and do research and contribute to policy. Is that the system should respond to the legitimate expectations of people. So, for example, non-medical expectation. So when you are a patient, how well you are, in a dignified way you are treated. So it's becoming a big. It's now seen as a big issue, but it has always remained. But now with given increasing awareness of patients' rights, choices, the role of informed consent, and so on. So, to give an example how Indian system has actually responded, I'd say very few countries have an act called Consumer Protection Act. Way back in 95, early 95, the scope of that act was enlarged to include healthcare. If you have paid for it, or even if you have not paid for it, if you suffer from a care that you have received, how do we address his grievances? So CPA allows the patient to seek care redressal fairly in a quick span of time, in 90 days or something, through simple procedures, meaning he or she can represent himself or herself with very little legal expertise. And thirdly, it should not cost the patient even though you are poor. So it's not easy to fulfill these three conditions in the context of healthcare, because rarely I can go and represent myself. So if I had my left leg amputated instead of right leg, so that's prima facie negligence. So I can go, but there are complications where surgery is done due to some negligence or deficiency I suffer later on. For me to prove that myself is impossible. So I have to have another specialist to give a certification or come and present on my behalf, which means I have to pay him in most cases. So it's not going to be cheap. And doctors or physicians who come in the process to support my grievances addressed also find it very demanding to go and read extensively, not only about the procedure but also legally how to take this forward. But then we have argued somewhere that CPA, in a sense, is a indication of the failure of the system, which is not responding, you know, to the expectation of the patient. You can also argue that it is a response to correct the failure in the system. So in that sense, you can see, even look at many other laws that have been framed later on, having a protective or preventive effect on the health of the community. So environmental laws, for example, laws relating pesticides, though it may not be so effectively implemented, but then we have an act, Water Act, which is one of the oldest in the country to control pollution. So we have many such acts, hundreds of them, which can all be linked in a way to promote public health status. To the extent they are becoming more effective, in that sense, you can say it is more holistic in that sense, but then also reflects the complexity of public health challenges. You know, so that's.
So more recently, you had led a report committee that tabled its report in the assembly 3-4 years ago. Can you say a few words about that?
Well, actually, that was in Tamil Nadu Assembly, and very interesting experience. It's part of as part of our government's efforts to roll out the universal health coverage, the concept of universal health coverage. Predates announcement by the government of India 1918 August. Two years prior to that, even 3 years, 2015-16 onwards, we had piloted in Tamil Nadu in 3 blocks. One block from Pudukkottai district, one from Krishnagiri, one from Vepur. And what we did was basically concurrent documentation of those efforts at the primary care healthcare level, which is even more particularly the subcenter level, what we call. That's the closest to the community we have a formal public health system. What changes were brought in by design on paper and on in practice, literally brick by brick, how it developed and its impact in terms of access to care, financial burden, these two factors. So we had nearly for 2 years we followed right from the conception to 2 years from then on. All that we, so in a sense it was a design of the study, execution of the observation, analyzing, and almost on a monthly basis we would have a review with the secretary along with this group, and as part of a larger discussion we would be asked to present and look at the progress. So to demonstrate a simple observation. I can call it simple in a way, but then we had to spend crores of rupees to demonstrate that. An idea which had its origin in 70s, which is that if you deliver primary care of a good quality, people will start using public system. As simple as that. People who are using otherwise private providers would seek care from here, and because they are now coming to public health system centers instead of private, and they would not spend as much financially, they would have less stress. Very simple. And the other consequences of this is that those who were otherwise going to private, who are now coming here, or some of them before the introduction of the scheme were going to public higher level institutions, are now coming here closer to the home. So you are freeing up the resources at the higher level by not going there and then crowding. If you go to all public institutions at taluk and higher level, it's too crowded. So if 20 people are adding and going there, and if the 20 are coming here, you have more resources released, including doctors' time here. So what you would save, and also something which is more difficult to establish, but people are now working by letting the people have access here. You are also hopefully preventing them from that illness becoming more complicated, and thereby promoting better health. So these are the implications of the study. So from 67 pilot sub-centers, based on this evidence, and it was presented and it's there in the record as they issued a GO to scale it up the next year to close to 1,000 centers. And then right now we have up to 4,000 sub-centers. There were a bit ups and downs in the progress because of COVID and other differences with the government. But essentially that model continues. So again, we were asked to do a similar study 2 years ago. So we had to demonstrate that during COVID, actually it helped to have such sub-centers, to have continuity of primary care, namely for antenatal care and TB and other services. And in Virudhunagar and another district, a comparison of such centers with such centers who had not been upgraded to show the differences. So that's a unique study of a follow-up of an effort by the government to collect evidence to support such initiatives, continue and scale up. Scaled up now in the last 6 years. From 67, there are now about 4,000 such centers. There were modifications after that, building on this. Of course, in 6-7 years, you have to modify a little bit in terms of quality of the health providers at sub-centers. Instead of someone with a better qualification, but the model is same, and the original evidence comes from here. But what central government did was to go in the same direction, which was evolving. It was not formally declared. People like us would argue that there is nothing new in this whole idea. Just that we forgot, we abandoned the sub-centers in the 80s and 90s. So late 70s, we had the sub-centers with two workers, multi-purpose workers, male and female, and all the sub-centers. Over a period of time, due to financial reason, they, as the male workers retired, it was not replaced. So they just went along, and we, thanks to the UHC, it's like the old wine in a way, new bottle. But UHC came with a lot, again, renewed political commitment with a larger range of services.
So has the central government taken from this your study and then
No,
applied it other places?
it was all widely circulated. There were some differences as a result of this model, what we tried in Tamil Nadu in terms of manpower requirement. So that's a natural discussion that perhaps would have anyway taken place. Whether, because we were getting funds from central government, to what extent we should follow the model proposed by
It's more of an
center.
insurance model, right?
That is for the higher level care. Insurance is for the higher level. This is for primary care. Of course, for the insurance also, we have done some studies which had some impact in redesigning some elements. So that's the summary of what we did the last 5, 6, 7 years with the government.
So I just, before we kind of close, I just also want you to talk about that multi-country study that you did. Before we go to more lighter scheme of things in terms of your time in hostel and as we close, yeah. Can you say a few words about the multinational study or multination study?
There were two large multinational studies I was associated with, and I also had the opportunity to have some of our colleagues, Umakant Dash and Debashish Acharya and a few others engaged in. But let me say something about the second multinational, multi-country study that we did. The title of the project, I would say project, which resulted in a book. It's called Good Health at Low Cost, What Makes an Effective Healthcare System. That's the title. That's the title of a study funded by Rockefeller Foundation way back in 1985. And they had 4 countries at the time, Kerala, Sri Lanka, China and Costa Rica. 25 years later, same Rockefeller funded study with which we were engaged in, same title, Good Health at Low Cost, What Makes a Healthcare System Efficient. 25 years on, what is the way forward and so on. This time, there were 5 countries, Tamil Nadu, Thailand, Bangladesh, and Kyrgyzstan, Ethiopia. Now, I would not I don't want to go into the selection of these countries, but let me state the question. Then you may understand why these 5 countries. Question was of the project, then and now, the first project and the second, that countries with at similar level of economic development have performed differently with respect to health status. So there is something called Preston curve. So if you plot the per capita income or income on the x-axis, y-axis, you have the life expectancy. So you have a curve as the income goes up, life expectancy, but then it becomes increasing at a decreasing rate. So it's not as steeply improving as income goes, but the delta changes are falling, I would say, very marginal improvement. So at any point of income, you'll find a few countries above and below the curve. So basically, if you take the Tamil Nadu per capita income. It is somewhere above the curve, and there are some countries with a similar, after adjusting for PPP, below the curve, and there are countries on the curve. Okay, on the point. So both Tamil Nadu and countries or regions below the curve are similar income, but they are performing quite significantly differently. So the question is why? What makes Tamil Nadu say health status better than comparable regions?
So what did the study show?
So, and then you have Thailand at a higher level, and then Ethiopia at lower, you know. So it's a very interesting study where we had to go back and forth, being in, unlike Thailand or Ethiopia, which is like one state of country here. We had to constantly, we were perturbed by, when you're looking at Tamil Nadu, you have to look at other states as well. But the point is this, that look at, they chose a set of researchers from each country who have been in dabbling with their own healthcare system for the last 25-30 years, and they are fairly familiar with the literature and the evolution. Have a quick answer to this, tentative, you can call it. And then they should be able to say something comparatively as well. So what we ended up actually doing, in about 12 months, the book was out. We had about 3 or 4 regional conferences and so on, the team. That we were basically endorsing the results of the study carried out in 25 years ago.
Okay, yeah.
So what are they? So each country, though at different levels of economic development, in terms of healthcare, they've all gone through certain 3 or 4 stages at different points in time, but they've all gone through certain stages. So that's the commonality. What are those common things? One is, of course, to have a good, reasonably good evolving primary healthcare system, a good, within that primary healthcare system, a good drug distribution system, reasonably good HR, human resources deployed, diagnostics, etc. So we pointed out through this comparative study that all of us have gone through putting in place these things. We may have taken 5 years, somebody else taken, but no one has bypassed these things to show that we have done that. So therefore, invest more on primary healthcare. I mean, there are so many ways of emphasizing this. Anyway, despite that, our investment in primary healthcare is not still as much as we would all like it to be. But that shows the policy challenges. It's not mere lack of finance, but belief that investment is worth that much. So that's the lesson of this comparative study. This was funded by the UK government, a 5-year time period, and it was led by London School of Hygiene and Tropical Medicine. No, this is Rockefeller study. I'm sorry, this is Rockefeller study. We were part of a consortium of a study funded by UK government for a 5-year period, looking at various aspects of healthcare system. So we had an MOU with the government of Tamil Nadu. The GO was issued by which for 5 years we were able to get access to people, officials, and that continued for 10 years actually. So we have, so that actually brought us closer to the government. The only condition that we promised to the government, that we will not financially ask any help, and whatever we publish will be shared with them, and we will follow that protocol. From the funders' point of view, we had to demonstrate that what we are doing is it's a felt need, is a kind of public demand from the public policy point of view. So we have the GO to show, In fact, all the questions and research questions were formulated through a workshop internally with the government. So it was not something that we
Randomly,
formulate
yeah.
and give me the data. So this is one important aspect of what we call implementation research. So in public policy, when you are actually doing a study, at the end of it, you don't give some statistical estimates, which will mean Greek and Latin for them. So right from the early stage of formulating a question that they feel, answering that question would be seen would be beneficial, and some
Basically, formulating the question from the field, actually,
from the field, but in engagement
with the
in
government.
discussion with them. And therefore an implementation research will have to be sensitive to the perceived and real needs of the people who manage, formulate, and of course the people. That's how we characterize our study, what we do.
Thank you, sir. This kind of shows your engagement with the public, and also
In one line, permit me one more minute. One line summary of all our research is this: that to what extent the benefits of public spending on healthcare has reached people at different
various levels.
socioeconomic
Yeah.
status. So the whole study, all the 15 PhD studies and other funded studies can be made as response to this question. So there are methodological questions, there are measurement problems, there are actual data collection, quality, and analysis, and presentation, and engagement with the government.
So
So that's
just
the summary of our
excellent.
work.
So basically, we have discussed your research, academic, and also public policy expertise, and your contribution to the public policy debate, society, various things. I just want to also kind of request you to highlight the role of IIT Madras, the role it has played in your development and also achievements. Just to kind of
So one thing I should highlight is that the notion of what is called about the ecosystem, as they say, is the kind of freedom you have, academic freedom you have, autonomy you have. So no one tells you do this or that. The assumption is that you are spending your time fruitfully. That's an enormous freedom, and you can be fairly anonymous and keep doing your work. Whom you work with, whether he is from this department or that department or within your department, or even recruiting your own PhD students. So I've had of the 16 students who have passed out, I've had PhD students from mechanical engineering background, commerce, history, sociology, of course, economics. Some of them are from government,
medical side also.
and the medical side. And in addition to doing joint supervision from others. So diverse disciplines. My only condition was this, that he or she should be interested in public health policy, and we will leverage on his or her background, not necessarily someone with an economics background alone. So because irrespective of your discipline, there is something that you can contribute to the design and perhaps implementation or evaluation of public health
So IIT,
system.
IIT Madras is a natural haven for interdisciplinary research.
Naturally, I would say certainly from the point of view of recruiting PhD students and promoting the discipline of public health policy with contributions of scholars coming from diverse disciplines, which may be more difficult in other setup. Also, the Center for Technology and Policy, which I happen to be coordinating since 2013, is a good development thanks to former director Bhaskar Ramurthy and others for giving some corpus fund to start this. The idea is to bring our own faculty members, students, including alumni and other startups, were working on public health issues by way of producing new research, innovations, products, and ideas, procedures, uh, how it can bring about a change in everyday quality of life of people, be it public health, be it education, be it energy. So we are able to build on that, and opportunities to work with people with diverse background in these disciplines. Took some time, of course, uh, very enriching in many ways. Of course, thanks to COVID, it disrupted that because a lot of it was based on field work. But we are now
Getting
evolving
back.
again.
Yeah.
So that's one big landmark. Apart from the fact that wherever with the department I've been associated with, also allowed me to work with this faculty from uh, various background. One of my recent faculty, PhD scholars with Professor Sri Kumar from philosophy on informed consent. Likewise, I've had. So it has been very enriching that way. In teaching wise, of course, uh, we need more time to talk about that. Thanks to the 5-year program that we launched,
MA program. Yeah.
we were able to design and offer really a large range of courses. I should say, even before that, way back in 93, I think, or 94, I introduced a course on environmental and resource economics for the BTECs. We used to have 30, 40 students every year, every semester I offered. That's when I was actually trying reading a bit on sustainable development. You know, the famous report on sustainable UN report had just been launched, and
Brundtland. No, no, no.
Brundtland report, and all my friends working on this area whom I knew at that time, who were not in IIT but elsewhere, I was able to benefit from them and have it as part of this course on medical ethics as well. And quite a few, the famous course, I would say famous because I also did that course as a PhD student, called Technology and Development, where the book Small is Beautiful by
E.F.
E.F.
Schumacher.
Schumacher, which after having done that, we've all been part of that course for the later generations of students. And besides presenting that book as, you know, marriage at the marriage function of many friends as a present. So that's a book that we all enjoyed, and we have grown thanks to Schumacher and those ideas. We are able to practice it through our research by forming our own groups and
Appropriate technology.
appropriate technology. But my own involvement is more on
Yeah. Economics.
primary healthcare, economics of healthcare. But I was able to work with other groups. Now, last 10 years, we're also part of a very big national effort by the Department of Health Research and ICMR in evaluating healthcare technology, particularly health technologies, devices, for example, that could be supported through public finance. So we need to justify, should government spend 100 crores on these devices, which will benefit the people? How definite we could be. So look at the cost and effectiveness. So we have been part of that body, besides other bodies as well. So all these were made possible because of the environment here, which allows you to play a role uh, at that level, and thereby extending the discipline as well in the Indian context. It's one thing to do technology assessment in Germany. Of course, the principles of evaluation will be the same, but quite another thing to have it done for a new product, such as even meet something that measures your hemoglobin at field level in the Indian context. You need, it's not a mere question of lack of data, so and collect it. So, what data you need, how you go about collecting, how do you design study to collect the data. So, that's the uh, challenge there. So, we have been able to engage with that. The system allows you to pursue those things. So, uh, that's the enriching part of the institution.
So just before we conclude, any interesting anecdotes about IIT Madras that you would like to cite?
Quite a few. Well, I would say learning from the institute, uh, we had this ozone as a
Zero waste
as an
management.
institution, okay, as a part of the system, a mechanism for handling
Waste
resources, waste from domestic and hostel. I was part of that
for
for
several
nearly
years.
about
Yeah.
6-7 years,
Yeah.
particularly during COVID time.
COVID. Yeah.
The enthusiasm and commitment with which the ozone workers, uh, were engaged. A lot of insights, practical challenges. One practical challenge is to make our residents segregate
Segregate.
and
Yeah.
give,
Yeah.
which I realized that, and it gives a lot of insights about human behavior, of course, and therefore even in designing, if you want to scale up as a policy, let alone a small system like this, but at the aggregate level. So I don't know if this is an anecdote, it's a big experience in a sense. How do we reduce human tendency to uh, tendency to minimize waste? And then it doesn't stop there. After that, how do we handle the waste itself, technological options and disposal and so on? But in terms of other everyday life, in a way, it's related to waste. You can say I was narrating very briefly with Kumaran before we started that use of toilets, access to toilets in our campus
It used to be
during
a
my
major issue.
PhD
Yeah.
days and right through up to even late 70s, 90s, I would say. Even in this building where we are now conversing, having this conversation, the ground floor of ad block used to have toilets and but become very difficult to use. Then we would run to library. Then we would go to MSB, ESB, and all buildings. So always a challenge in accessing toilets. Every day I will have some story to narrate. So much so that it became a kind of habit to visit toilets in the campus as a student as well as a faculty, just on my own, and start cleaning in a way. Especially during the quiz time and other exam period when I used to be the HOD head. I will insist on, I will request the engineering unit as well as the concerned person to pump the water. I should be able to hear the water falling on the tank. And then next day, early morning, I will come. Make sure that toilets are clean or clean it, because the boys, the students will rush just in time before the quiz, and they also would have the urge to use the toilet. So this is a very interesting, call it episode, but it's a long episode of almost 10-year experience. I can recollect, and one day I would even write a small essay on my experience with toilets. So things have vastly improved. Of course, they are all very different now. There are many other things. One thing I want to say is about the food in the hostel. Never ever, except days when I was away on a library work as a PhD student, had I missed eating in the hostel. first boy, first person at 6:45, or at least first within the first 10 people. 11:45, 6:45. Thoroughly enjoyed my meal every never missed it. I can say hardly we had this quark at that time where rarely we'll go there around 11 o'clock to have a cup of tea or so. But eating outside was also not possible. But never miss the hostel food because good quality of food. I don't want to compare now and then, but I'm just saying my experience then, that time. Really enjoyable. Overall, life from 83 to
2024,
88, and from 88 to uh,
24.
2024 March as faculty, and now an extended period as emeritus. Been very happy. When I joined 83, it was though it was called Department of Humanities and Social Sciences, but it had industrial management, broadly speaking. They had masters and PhD in industrial management as well. So we had more number of faculty on that industrial management. I have also done some as a PhD student, a course in accounting, also a course halfway through on capital financial management. Then I dropped that course after a while. But we had Elizabeth Kurian, Krishna Rao, V.S. Kumar, Evangeline Manikam. Later on, she joined. Then you have Malathi, Professor Malathi joined 86 or so. T.T. Narendran has been there, was there much before I joined. We had Professor R. Rajagopalan at that time, who retired later, about 15 years ago. I think he was 16 or 17 years ago. So we had opportunities to also to jointly supervise master's PhD students then. So I had myself two master's students, MS students. We didn't have masters in humanities and social science. We had masters in industrial management. I remember clearly two master's students. One jointly with T.T. Narendran himself. He worked on operational issues in drug management. Then I had another MS student from mathematics student, MSc mathematics. She worked on measuring hospital efficiency. That was a joint supervision with Professor G. Subramaniam, Srinivasan. Then my two PhD students, one with Professor Kamal Naban on quality of human resource recruitment and satisfaction of employees in regional ophthalmic institute in Chennai, and in comparison with Aravind Eye Hospital, again on health. Then with Professor G. Srinivasan, another student with mechanical engineering background, Professor V. Sudhir, who is now an associate professor in IIT DM, on using systems dynamics in waste management in Chennai. So plenty of scope even then for working jointly with IM faculty, not merely just a DC member, but actively promoting research with people from diverse discipline. So that characteristic was there very much there. It just depends on how you reach out and open where. So therefore, it reflects on faculty on that side. They were also open to that. I remember, to give an example other than mine, we had late professor of marketing management, Jayachandran, working collaboratively with I think Evangeline for a PhD student in marketing. So that lady was from Indian Department of Income Tax. So I can give more examples, such examples of collaborative work of faculty from industrial management and humanities. I can just, if I give me a few more minutes, I'm sure I can come out with 5 more examples. So that's the kind of nature of the department, which the title of the department gives. Humanities and Social Sciences can be interpreted in such a way that it sort of encompasses a wide variety of people with diverse background for collaborative work. So we never had actually issue of recruiting students from diverse disciplines, unlike some other departments had. So we end up creating new departments or ID projects and so on. We were able to practice it. I myself have few examples and others have examples. Of course, opening new such avenues also welcome. I also had supervised jointly with faculty from other departments from this department. I need not look for a separate platform to do that. So all that was possible, at least from our department point of view, and now even more with the creation of new departments. So I don't know if you need more comments on the nature of the department.
Now both the departments have become very big departments. HSS has almost 40
we are
faculty
now, in 2016, I remember 2006, when we had our department, 2004 or 5 onwards, 2 different departments, HSS and management. We were about 12 or 13 people. Now we have 40 people.
40 people. And plus they are also almost 30.
They have also grown.
So 70 people, from 12, 13 to 70 people. Before we conclude, would you like to add anything to the discussion?
Thank you. Certainly, before we conclude and thank the Heritage Center and the team, I would like to highlight 3 or 4 things about which I've already highlighted and we have discussed. But 3, maybe 4 things, very important things. One is that when the department was established, which is as old as the institute, and this is the case in all IITs, HSS department will be one of the founding departments, and that continued, academically speaking, to the curriculum of the undergraduate and postgraduate engineering students. But in 1981, 81, I think, as I mentioned earlier, Professor Interdisciplinary, then director, launched the PhD program in our department, and therefore increasingly we had more and more students, and I joined in 83 as a student. And also some of the faculty members who didn't have PhD completed that PhD for a period of time. That's one major landmark academically from the department point of view, and therefore as part of the department's contribution and therefore to the institute. The second is launching of the 5-year program in 3 disciplines. economics and development studies and literature. After the plus two students who were past plus two, we had that for nearly 14 or 15 years. So it had a good name and it evolved, and we also expanded in terms of faculty strength. Then after about 15 or 16 batches, there was an urge to try something new, offer something new instead of a 5-year program. So we had introduced a 2-year program, masters in the same 3 disciplines. The advantage of this is that those not only who could not join after the plus 2, but hopefully after their graduation, those who join would be more informed of their own choices and pursue what they would like to. So that's a very landmark change in our development, I should say. And of course, parallelly along with that, we strengthened our faculty. Now we have nearly about 40 odd faculty members, as I mentioned. We also have introduced a new interdisciplinary dual program in public policy, which I mentioned earlier. So just as a summary, I want to bring these up. We find more and more students are interested in elective courses that touch upon, that deal with public policy, technology, and so on. So therefore, we'll have to repackage and make it more attractive, no doubt, in all programs. But I want to highlight these 3 or 4 things. And also the increasing number of research projects that we get, both funded as well as for interdisciplinary research, which means that it brings not only faculty members from different disciplines within social sciences and others, also in making oneself more multidisciplinary or interdisciplinary in perspective. So with these brief summary of some of the key points that we discussed, I would like to thank you for patiently listening and giving an opportunity at the center, the Heritage Center, and Kumaran and Mamta and their team for this opportunity. Thank you very much.
Thank you very much, sir. It was a pleasure talking to you. And we covered the history of the department for the past 40-45 years. And I would also like to thank the Heritage Center, the NPTEL, and the team for giving this opportunity. Also, thank you for giving me this opportunity to interview and get to know more about the institute and our department as well. Thank you very much.
Thank you very much. Thank you very much.